Good afternoon. I'm Elyse from the University of Cincinnati, and I'm accompanied today by Sherry Hughes, who's from Cincinnati Cancer Advisors. And we will be hosting a discussion regarding breast cancer disparities. So I thank you all for attending. Sherry, in addition to being the Director of Strategic Community Engagement, is a big breast cancer advocate and advisor, and also a breast cancer survivor. Sherry, you want to say hello?
Yeah, hello, and thanks to everyone for joining in on this program. And it's good to be here with you, Dr. Lauer, so that we can talk more in particular about breast cancer and healthcare disparities.
So we'll get started. And as everyone's aware, breast cancer is a big problem in our country. And this year, there'll be about 300,000 new women diagnosed with breast cancer. Only about 2,300 men will be diagnosed. That equates to about a lifetime risk for a woman in the US of 1 in 8 to getting breast cancer. We now know that breast cancer is the leading cause of cancer death in women after lung cancer. Now, the good news is that most women are diagnosed with early stage disease, and there are about 3 million breast cancer survivors. So as we're going to be talking about some of the disparities in breast cancer. And I think one of the best ways to do that is to illustrate it with a case, something that we could see every day in our clinic. And this is a typical 45-year-old premenopausal Black woman who presents with a new left breast mass. The mass measures about 2.9 centimeters on ultrasound and breast MRI. The axilla showed no palpable adenopathy, and the ultrasound revealed no abnormal lymph nodes. She had a biopsy that showed a grade 2, markedly ER/PR positive, HER2 negative invasive ductal cancer, very garden variety breast cancer. And the Ki-67, which is a marker of proliferation, was slightly high at 15%. Her sister had previously been diagnosed with breast cancer at the age of 54, and the patient underwent genetic testing at the time of her diagnosis, which was all negative. She underwent lumpectomy with sentinel lymph node biopsy, and at the time, the final path showed a 3.2 centimeter grade 1 invasive ductal cancer. Margins were negative, and 1 of 3 sentinel nodes was positive for cancer. She subsequently had an oncotype sent on the tumor, which showed a recurrence score of 22, which suggested that she could indeed benefit from adjuvant chemotherapy in addition to tamoxifen. Remember, she's premenopausal, and she also completed radiation. So the question for all of us is, what do we expect her outcome to be? And would it be the same if she were white or Black or Asian? So we know that unfortunately there are some racial disparities in breast cancer and in the outcomes. On the left-hand panel, you'll see a recent figure from the Centers for Disease Prevention and Control looking at 5 racial groups: white on the far left, followed by Black, American Indian, Alaskan Native, Asian Pacific, and finally Hispanic. In the light or pink bar is the incidence of breast cancer in each of those racial groups, and in the darker pink bar is mortality. And as you can easily see, the incidence of breast cancer is highest in the white, followed by the Black patient, and then further down the road is the Asian Pacific and Hispanic. But when you contrast the mortality rate from breast cancer, it's higher for the Black woman than it is for the white woman, even though we know that there are more white women diagnosed with breast cancer in the US than Black. I think of equal interest is if you look at that Asian Pacific Islander, she actually has an incidence that's less than the white, Black, or American Indian, but look how low her incidence, her death rate is. It's almost half that of the Black. So clearly there are differences in outcome for the white, the Black, and certainly even the Asian Pacific woman. Now, it wasn't always like this, and I think the figure on the right really illustrates that, because this looks at the outcome per 100,000 women. And as you can see, if you can find your eyes initially to those top 2 curves, the lighter pink curve is the Black woman, the darker pink curve, the white woman, and then that's followed by the Asian and American Indian and Hispanic in the dark Black curve. And as you look at the top way back in 1980, the outcomes were the same for the Black or for the white. But look what happened over the next 40 years. There was clearly a divergence of the curves, and we now see almost a 14 difference between the African American or Black woman and the white woman. So something's happened in those last 40 years to change the outcome for our patients and for us. This was just presented just about 3 weeks ago at ASCO, looking at 140,000 women from the National Cancer Database. And these are patients that fall into one of 4 racial groups: non-Hispanic white, Black, Hispanic white, and Asian Pacific Islander. These are women who all have early stage estrogen receptor positive breast cancer. And it's looking at their outcomes after their initial surgery. And they all received adjuvant endocrine therapy. And as you can see, there is a disparity between the recurrence score, and this was generated by the usual oncotype, in the Black, which was statistically higher than the recurrence score in the non-Hispanic white. And you can see this is illustrated by the blue bars. And the overall survival also differed between the non-Hispanic white and the Black. And again, that Asian Pacific Islander, who has almost the same recurrence score, a little bit lower, a little bit higher than the non-Hispanic white, a little bit lower than the Black woman, but look at her survival, it's very different. So again, I think this illustrates that there are differences in the different racial subgroups. So we now know that breast cancer is the leading cause of cancer-associated death among Black women. As I said, it's still lung cancer overall. So why do we see these differences, and why do we have this disparity among the different races? And I like to think this into 2 big pots. The one pot's biologic, which is like tumor biology and genomics. And then the other pot is what I call the non-biologic pot, which is access to healthcare, socioeconomic status, education, et cetera. I don't know, Sherry, you want to comment on the non-biologic pot, how you think we should think of it?
Yeah, definitely. I see that oftentimes there's not a whole lot that might come into play with the tumor biology, but with the access to care and us talking about healthcare disparities, I think that that's a large focal point there, because in Black women in general, I do believe and still feel like there is always a lack of trust within the African American community, period, in healthcare initiatives, because of the historical aspect of what has played out in the past. So I do think we have to look at the access, Dr. Lauer, as well as the socioeconomic standing and where our people are in terms of the type of care that they actually have access to.
Mm-hmm. Yeah, very, very important. So we have to be mindful of those. And again, those are sometimes modifiable factors, I would say. So things that we can work on improving access and hoping to dispel some of the myths that people might have about their healthcare delivery. If we talk about the biologic, it really falls into that tumor biology or genomic categories. And those are things that we're kind of stuck with. But I think we can illustrate that as our case 1 story continues. And our patient in case 1 never forgot her annual mammogram. In fact, she had a normal mammogram just a few months before she felt her breast mass. At the time of the diagnostic workup, the radiologist informed her that she had very dense breast tissue. Both the radiologist and the patient wondered why she didn't have an MRI sooner. In fact, she didn't know she had very dense breast tissue until she was undergoing this diagnostic evaluation. And unfortunately, this can be sometimes a very common scenario as well. And we see this a lot, particularly in our younger women, that they're unaware of what their breast density may be. So we know that women of color have an increased breast density, and this increased density clearly increases breast cancer risk. And on the right-hand figure, you'll see the 4 different density patterns that our radiologist often will inform us on a routine mammogram. And the first 2, almost entirely fatty and scattered areas of fibroglandular density, really represent kind of the normal finding. And the latter 2, heterogeneously dense and extremely dense, are categories of D3 and D4 that clearly increase the risk that that woman will develop breast cancer. On the left-hand side, you'll see that we know that the increased density that women of color experience is not just because of BMI. And even when you correct for that or adjust for that, that women that are white have fattier breast tissue, and women of the Black race have denser breast. And again, this dense breast can increase that risk of cancer. Now, there was a time when we thought the only way that increased density increased the breast cancer risk was it made mammographic imaging less clear. And I think that's pretty obvious on the figure we just looked at. The denser the breast, can't see the snowball in the midst of the breast tissue is quite real. But we now know after further study that increased breast density is an independent risk factor for breast cancer development. And in fact, if you have that D3 mammogram, that heterogeneously dense, it increases the risk by 1.2 times. And if you have that D4, that extremely dense, kind of you can't see the snowball in the mammogram image, that actually doubles the chance that you could develop a breast cancer. Now, what can we do about that? Well, as illustrated in our case one, as soon as the radiologist recognized dense breast, and obviously she was undergoing a diagnostic evaluation, she had a breast MRI. As you can see on the right-hand side, that dense breast mammogram makes it very hard to identify that little round circle that's easily identified by the arrow on that breast MRI. And again, that's the same patient. That's just looking at the dense breast versus the MRI. We know that MRIs are most sensitive tests that we currently have for the detection of breast cancer. And the best way to currently look at women with dense breast, it's not perfect. It's not a test that should be used for all screening, but clearly it's our most sensitive way of finding a cancer in a woman who has dense breast tissue. And as you see in a recent study of 1,300 women who were undergoing breast cancer screening, by far and away, the MRI in the blue bar was able to detect the cancer compared to the mammogram. So Sherry, you've been part of an initiative in our state of Ohio to help with women with dense breast. I don't know if you want to comment on your role and how this led to Governor DeWine.
Yes, well, certainly I can look back at the imagery, Dr. Lauer, that you just showed and showcased, and it could very well have been my imagery because I knew that I had dense breast many, many years ago because I lost my mom to breast cancer. And like a couple of the case studies, I had no genetic markers that, predisposed me for breast cancer, but I had that family history. So it kept me alert and kept me looking for ways to, make sure that I stayed on top of everything. So I actually was diagnosed with breast cancer in 2019, and I had no current issues with my breast. I was healthy by all accounts, but I started seeking advanced screenings through the breast MRI. I was able to get that just as a means of perhaps another baseline. And that led to the discovery of my very small cancer at an early stage. So grateful for that. So certainly once I completed treatments of chemotherapy and surgery, you could say also radiation and another adjuvant therapy. After that, I decided that I needed to do more to help other women to be aware. So I started to get out and do more advocacy work in the community and came across a fellow survivor, Michelle Young, who was stage 4 literally, she helped to change the paradigm here in the state of Ohio. So I joined forces with her as she was looking to find a way to make sure that women like us knew about breast density, and also that we could fight to help other women across the state be able to have measures to help them have access to higher levels of advanced screening. So along with Michelle Young, other of women in the community and across the state of Ohio, also with bipartisan representation from our area representatives here, which was Representative Jean Smith and Representative Cedric Denson. They actually paved the way forward for us to fight and lobby to get breast legislation in the state of Ohio called House Bill 371. And that would ensure that it would give women across our state an opportunity to get the advanced screening, and also make sure that insurance companies and providers were on board so that it could be covered. It also enabled better language for the for doctors to be able to make sure sure that their patients would understand their breast density and that it could very well be an issue. So we worked on that for likely a year to two, and we did get that law passed last year, June of 2022, with Governor Mike DeWine. And now the state of Ohio, we have dense breast legislation.
Yeah, thanks, Sherry. You know, it was such a valiant effort. And I tell you, it was the first time I'd ever worked on a project in which we had Democrats and Republicans all unified and everybody working together. You know, who was going to fight that? So again, this is tumor biology. This is breast biology of dense breast. And we know that can increase the risk. And so this is something that we can help with, is to make women aware of their density and also offer them a potential solution, which is supplemental screening. So there are some features that unfortunately we can't change, and that's often that biology. So we know that in addition to denser breasts, that Black women often will have cancers that are a higher grade, hormone receptor negative or triple negative. And if they have an estrogen receptor positive cancer, it may be of that basal subtype. We also know that germline and somatic mutations can provide targets for therapy. So it's very important that we make sure that we identify patients that need that testing, either in the germline setting or in the somatic testing. But there are some barriers to genomic testing. I know in your work and in your role as a breast cancer advocate, you've probably encountered some women not willing to think about it. I don't know if you want to comment, Sherry?
Yeah, I think oftentimes women really don't want to think about it because they don't want, they don't want that diagnosis of breast cancer. However, it is imperative that we reach out into the hinterlands, if you will. We reach out to the various communities and make sure that women are aware that the best possible thing for them is to be aware and to get an early detection if they have breast cancer. So we branch out to rural communities and we talk to people with various different diverse backgrounds and disability. We cross those racial, ethnic lines and make sure that no woman, no man is left out, and making sure that we get the information about cancer in general. What we're talking about today is breast cancer. And we certainly look to those communities where folks are underinsured, Dr. Lauer, because we know that these are barriers to them getting tested, period, but certainly big barriers for genomic testing, which really kind of refers more to hereditary genetics.
Yeah. Well, I think it's so key today because as our knowledge expands and our treatment improves, so many of our treatments are going to be targeted against our genes or our tumor's genes. And so it's appropriate that we continue to monitor that. So just as an example of how targeted treatment can improve an outcome is the story of PARP inhibitor. And first of all, I think most of us can agree that a woman who is newly diagnosed with breast cancer should have that early discussion as to whether she might have a BRCA or other inherited susceptibility mutation. And there are going to be women who opt to do it, women who don't, but at least we should make that available and have that chat. And it's so important today because we know for those women that have advanced cancer, if they have a BRCA or a PALB2 mutation, that they can truly benefit from a PARP inhibitor. And as you see in the upper right panel, those patients that have germline BRCA mutations and metastatic breast cancer have almost a doubling of their survival if they take the PARP inhibitor versus chemotherapy. And more recently, as you see in the lower right-hand panel, even women who have early stage but more high-risk breast cancer, meaning node positivity, then when they have a germline BRCA mutation, they can benefit from taking the PARP inhibitor olaparib to prevent their cancer from coming back. So making sure that we offer to all of our women the possibility of genetic testing when they're first diagnosed is very, very key. When do we test for other mutations, particularly the other somatic mutations? I think most of us feel that it should definitely be done when a woman's diagnosed with metastatic disease, because that tumor analysis can often provide us with new targets such as PI3 kinase and others in which we can potentially target her treatment and provide her a better outcome. So we need to be aware of offering these tests to all of our patients. And in particular, as Sherry mentioned, overcoming some of those barriers, working on outreach and ways to help to facilitate that for all of our patients. We also know that Black patients, as well as others, are going to have some diverseness to their tumors and to their outcomes. And we just showed the racial disparity that truly exists. And this suggests to us, particularly for our women of color, that we need more participation in clinical trials, something that we all really struggle with in every form of cancer. Sherry, your thoughts on clinical trials and where we are with that?
Yeah, definitely. When you look at this, this data here is pretty much just speaks for itself. When you see that there's only 3% of the participants in clinical trial being Black women, then that means that when all of the definite trial information are coming through to help create new medicines and new drugs, if we're not a part of the studies, then that is doing the Black woman a disservice, of course. So the data is just really alarming to me. I think that it goes right back to some of those barriers, Dr. Lara, that we were talking about across racial, ethnic lines and minorities, the lack of trust and access and awareness and cost. But right now, I think it's so important that I have been trying to get the word out to women of color, to every woman, but certainly women that are of color, because we have the highest mortality rate than any other woman when it comes to breast cancer. So we've got to be participants and be eager participants in different studies so that we can find and have more medicines that are being created that will help to benefit us as well. That is something I think that we can't speak enough to, and we have to really get out there and do the hard work to make sure that women of color are participating in these trials.
So very, very important. Do you have, obviously there's no easy solution to this. I mean, we've all struggled with this. And I think as we've got more data regarding the disparity, it's so important that we try to come up with some other solutions to help with this. Do you have thoughts on how do we overcome this lack of trust? I mean, that's something that I think is essential that we really work on. Do you have thoughts on what we can do?
Well, I think that we can continue to walk the walk and talk the talk and make sure that this information gets out there. But that's one of the things I've been doing through my advocacy, Dr. Lauer, is I've been getting out and speaking with women all across the country, right here in Cincinnati and Ohio as well, but all across the country to let them know more about breast cancer and to let them know about clinical trials and studies. And I've been participating in them myself so that I can go back and also be an example to say, hey, this is something that I have done or something that I am involved in, to let them know that, you get better outcomes, not only for yourself, but for, the women that are out there that are in your particular ethnic background, the women in general, across the board, when we all show up and when we all participate. So how do we do this work? Well, we have to continue to have boots on the ground. We have to continue to get out there and talk to and meet the women where they are, meet them where they're at, and make sure that clinicians are talking to women when they come in, to let them know what is available, to take some of the myths and fear out of these clinical trials and what have you. Oftentimes, what women fear that, you're being used as some type of guinea pig or something. Well, oftentimes if you're fighting a cancer and it's very aggressive, then, you're going to try to almost do whatever you need to do to make sure that, you survive. And some of that will come with different trials that are out there. And a lot of that you're benefiting from comes from not only the trials, but the different other mechanisms that have come before us to give us information on how to fight these cancers.
Right. I think you're so spot on with that, but I think we also have to recognize in our offices, including our clinical trial offices, that we need a bit of diversity in our workforce, because, some of our problem is identifying, as you alluded to. You need to see somebody that's been there, done that, and that it's a safe clinical trial and why it's being done. And sometimes I think it helps to make sure that our workforce is very diverse and that we can handle the questions and the problems. A woman may be very hesitant to talk about how she has no access to care because she can't be in the trial because it means she has to come in for extra blood work and no one will take care of her kids. So she needs to feel free enough to say those things and to be able to have potentially some of those solutions. So
Yes.
I think, it's truly a big effort on all of our parts, both on the office side, the clinical trial side, as well as patients talking to each other and really making sure of all the awareness there. So we know that there are breast cancer disparities, and I think that we now truly have a call to action. And this is really a three-pronged attack to try to, first of all, be aware of the disparity and to offer potential solutions on what to do to help with that. So first of all, we need to be aware that diverse populations may experience different outcomes, and we now have really good science suggesting that this is true. We have to understand that Black women may have worse outcomes due to later stage diagnosis. And as Sherry mentioned, I think one of the key things is women, when they have their mammogram, they need to know what their breast density is. They need to know if in their particular state they can have supplemental screening provided to them or what some of the solutions potentially can be. And if you don't have it in your state, think about legislative action. It can take a small grassroots 2 or 3 women with 2 or 3 doctors and 2 or 3 legislators. All of a sudden you get the bill signed. It isn't overnight, but it can happen. And it can truly improve that access to appropriate screening. We also know that we need to be aware of tumor biology and we need to be aware of our biology. And so that suggests to us that we may need germline and somatic genetic testing done. I think most of us believe that certainly germline mutation testing should be offered for all of our women. That doesn't mean they'll want to do it, but it should be discussed with them and how some of the outcomes could be important to them or not important to them. And then somatic genetic testing should be done in all women who have metastatic disease. We need to find those targets so we can offer them the best targeted therapies. And then finally, that third prong is of the call to action is partnering. And this means that we can enhance and access to care as well as treatment compliance. So many people today even start hormone therapy and only half of them finish 5 years of the recommended hormone therapy. So we need to figure out what can we do to improve compliance. Provide a diverse workforce, as we mentioned, can help with participation in clinical trial participation. So I think all of that is so very important in our population. Mm-hmm. So to conclude, we know that representation matters both in the workforce as well as in clinical research. Racial disparities in breast cancer outcome may actually widen or worsen with increasing use of novel therapies if we cannot universally apply them. And that gets back to that testing, make sure we're offering testing. And we must strive to achieve equitable care to provide the right care at the right time for all of our patients. I want to thank you, Sherry. It's so good to see your face and hear your voice again. So take care, and we'd be more than happy to answer questions as they come through. So thanks again.
Thank you.